Hello everybody, I'm Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. When a patient comes to you in your OPD and she complains that she has pain during sexual intercourse, tell me what is the thing you do? I will tell you. The first thing you do that you make a note, dyspareunia. But I want to break this myth today that all that hurts during sexual intercourse is not dyspareunia. It can be many other things. So we will discuss what all it can be during today's session, and furthermore we'll discuss what exactly is dyspareunia, what are the types of it, what are the causes of it, how to clinically evaluate this patient, and then we'll go forward with the investigation modalities and a brief description about the management plan. In simple words, let's decode dyspareunia today. Dyspareunia is a vaguely used term. Let's understand today what it actually means. This figure shows an schematic representation of the genital tract of a female. What I want you to understand is that every painful intimacy is not necessarily dyspareunia. If the pain is at the level of vulva, it's known as vulvodynia. If it is at the level of vagina, it is called vaginismus. Pain at the level of upper vagina and cervix is called superficial dyspareunia. If the pain during sexual intercourse arises from the uterus or the adnexa, it is called as deep dyspareunia. Two separate terminologies first you must understand. Number one being sexual pain disorder, and the second one is called genitopelvic pain or penetration disorder. Sexual pain disorder means pain that occurs only during sex, that may include dyspareunia, vaginismus, and vulvodynia. As vulvodynia and vaginismus may even be present during non-sexual situations, these painful conditions may be better grouped as genitopelvic pain or penetration disorder. If you intend to understand the three terminologies separately, dyspareunia means genital pain that occurs specifically just before, during, or after intercourse. Vaginismus is a pain which happens during vaginal insertion. It can be during sexual intercourse, vaginal examination, and even with activities like insertion of a tampon. Among these three, only vulvodynia has a time duration. The pain has to be persistent for more than 3 months, and this also involves activities like insertion of a tampon. Having understood the difference in the meaning between these three pain terminologies, today we'll focus only on understanding about dyspareunia. So dyspareunia can be subcategorized into two groups, superficial and deep. Superficial means that the pain is at the vaginal introitus with initial penetration, while deep dyspareunia means the pain that occurs within the pelvis with deep penetration. Superficial dyspareunia includes even provoked vestibulodynia. It can be because of pelvic floor dysfunction, vulvar dermatosis, or genitourinary syndrome of menopause. Deep dyspareunia has many causes, which include gynecological, urological, gastrointestinal, central nervous system related, psychological, and musculoskeletal. Classification-wise, deep dyspareunia thus can be classified into four groups: type 1, type 2, type 3, and type 4. Type 1 includes primary gynecological etiology, which can be extrauterine or related to uterus or cervix. Extrauterine causes are endometriosis, menopause, iatrogenic, or prolapse related. Uterocervical lesions can be endometriotic, PID, pelvic congestion syndrome, adenomyosis, fibroids, or even retroversion of the uterus. Type 2 includes comorbid condition, in which the common ones are urological, that is interstitial cystitis or bladder pain syndrome, recurrent UTIs, GI causes which includes IBD and IBS. Psychological causes like depression and anxiety can also cause deep dyspareunia, and myofascial pain syndrome as a musculoskeletal cause. Type 3 is the pain that happens because of central sensitization. Type 4 will be the group when more than one condition is present, like endometriosis may also be associated with interstitial cystitis. Then, to complicate the issue, there can be additional factors that may modulate any type from 1 to 4. These include social circumstances and also the genetic factors. Not to forget are the iatrogenic causes like trauma during childbirth, pelvic vaginal surgeries which cause fibrosis, scarring, and shortening of vagina, pouch of Douglas adhesions causing fixed retroversion of uterus, post surgical mesh or suture erosions. These are the causes which are often ignored but are very important causes of dyspareunia. Based on this information, how do you evaluate your patient? The most important thing, as always, is the history. The important thing is to understand and recognize the fact that taking history of sexual disorders is uncomfortable not only for the patient but also for the clinician. Determining which sexual activity in particular is painful can suggest specific diagnosis. You must also ask about bladder, bowel, or musculoskeletal system related issues, her psychological history, and medical conditions. Very important is to ask about a recent history of childbirth or any pelvic surgery. History of partner violence or sexual abuse also must be noted down. Remember that unlike regular examination sequence in gynecology, the order is reversed here and starts gently as a single digit examination. But first thing always is to inspect locally, followed by a single digit examination of perineum, lower vagina, upper vagina, fornices, and uterus. Record pain or tender points here. Correlate with specific patient symptoms. And then, if the patient allows you, go ahead with bimanual pelvic examination, and if required, a speculum examination can be performed at the end. Unfortunately, there is no confirmatory diagnostic test to establish the diagnosis of sexual pain or penetration disorder. In cases of deep dyspareunia, though, a transvaginal ultrasound may be of help. But I want to emphasize this point that care must be taken to interpret the results, as a structural lesion may not always be the reflection of patient symptoms. For example, if you find an endometriotic area or endometriotic lesion during your transvaginal ultrasound, but if it is not corresponding with the tenderness or pain in that area, maybe this is not the cause of her dyspareunia, and just treating it may not relieve patient of her symptoms. The best way forward is the trial of treatment based on empirical or plausible diagnosis rather than first trying to establish the cause. As far as treatment options are concerned, let's discuss surgical interventions or role of surgical interventions first. And let me tell you this. For us, the surgeons, when we find a lesion, we feel like operating it. But be careful, surgical interventions have a limited role in patients having dyspareunia. It can be done for a patient who complains of deep dyspareunia where a structural lesion is found to be the culprit, as in cases of endometriosis, adenomyosis, or uterine retroversion. Psychosocial interventions are options for all sexual pain disorders. These include cognitive behavioral therapy, pain management, sex therapy, and psychoeducation. Preferably, it should be offered to both the patients, either individually or in combination. The aim is to reduce pain and improve satisfaction by targeting the thoughts, emotions, behaviors, and couple interactions. Other treatment options which are based on individual case to case scenario include PFMT, pelvic floor muscle training, topical creams, antidepressants, anticonvulsants, anti inflammatory therapy, hormone therapy, neurotoxic agents like injection of Botox and radiofrequency or laser therapy. These therapies are individualized mainly based on the findings of clinical examination. In a nutshell, pain during intimacy may have overlapping symptoms, and the problem is the etiology of this is not fully understood. You must remember that when a patient presents with these problems, they are distressed and also embarrassed to share their problems with you. The mantra is making the patient comfortable and being a good listener. It will not only help to understand the underlying pathology, but will also help to guide the treatment and let the patient stick to the treatment protocols and follow up. That's all about dyspareunia in short today. Thank you.